Give an update on AccuBoost APBI. So non-invasive non-invasive image-guided breast brachytherapy, or the generic term for this technique, is a novel approach to partial breast irradiation. And what's exciting about this technique is, it's non-invasive, meaning that you don't have to place any catheters or devices percutaneously, but it maintains a high level of precision, precise targeting by using breast immobilization and image guidance for each treatment, each fraction. And this results in the ability to deliver the treatment without needing large PTV, which is different than other non-invasive techniques like 3D conformal and so forth. And that's what the true advantage of this technique is. What the system looks like is basically a modified mammography unit. The way the treatment works is the patient is positioned in the unit and the breast is compressed and immobilized between the compression plates. And the way we do compression is we don't need to get maximum compression like for a mammogram. The point is to immobilize the breast, and so we gauge that also on comforts to make sure that the patient is not in pain, as a woman may be during a mammogram. Once the breast is immobilized, we take a mammographic-like image. We can see where the surgical cavity is, typically outlined with surgical clips, but you can also go by post-radiation and post-surgical changes. And then we select an appropriately sized and shaped applicator to target the lumpectomy cavity. For APBI, typically I've been using a 1 centimeter CTV margin. And then based on the localization grid here, we attach the applicator above and below the compression plates. The applicator is then connected to a remote HDR Rhodium-192 source. The source travels through a circular channel in each of the applicators, and the applicator actually collimates the emissions from that source into a beam-like projection. We typically then repeat the process in an orthogonal fashion. We use 2 orthogonal angles to get a conformal dose distribution to the target volume, and this also decreases the surface skin dose as well. Initially, when this technique came out, we had simple round applicators, and now there's second generation applicators that has a central cone which reduces the skin dose by eliminating skin scatters. And I'll get into how those help in a little bit here. So what I wanted to do now is update you on the clinical trials that have been conducted in this. So there's been 2 prospective trials and a registry trial. In the first trial, we looked at a dose of 34 gray and 10 fractions, a standard brachytherapy dose. The dose, because we didn't have any indwelling catheters, we allowed the treatment to be delivered either daily or BID, and this was based on patient preference. We enrolled 40 patients. The demographics are shown to the table here. We selected an older patient cohort. The minimum age was 50. Most patients were in their 60s. All tumors had to be ER positive. They had to be less than 3 centimeters in size, so a typical partial breast selection criteria. Treatment was well tolerated. The acute skin reaction, because this is an external low energy source, we have to be mindful of what the skin dose looks like. It was actually very, very well tolerated. 73% of patients had either no skin reaction or very faint mild erythema. 28% of patients had moderate erythema. No one had moist desquamation. Typically, the maximum acute skin reaction, because of the shorter course, actually developed after treatment, typically about 2 weeks, and then resolved shortly thereafter. What we found in the first trial, while we were conducting the first trial is when the second generation applicators came out. So we had some patients that were treated with first generation and some treated with the second generation. And we found that the skin reaction was dramatically decreased with the second generation applicators, in that none of the patients treated with the second generation applicators had a grade 2 or higher skin reaction. This is the last time we analyzed the data. We had 43 months follow-up. There was 2 ipsilateral breast tumor recurrences, 3 contralateral new primaries. There's no grade 3 or higher toxicity, and the cosmetic outcome was 97.5%, good to excellent. This is an example patient at 5 years. You'd actually be hard pressed to point out which side was actually treated for her, so very good outcome. We're at 5 years follow-up, and we're currently in the process of analyzing her data, so hopefully we'll have that data soon. The second trial, we looked at a more convenient dose fractionation of 28.5 grade 5 fractions. And this came out of the fact that in the first trial, when we allowed patients to select daily treatment or BID, 3/4 of the patients wanted daily treatment. Patients don't like coming twice a day. Physicians don't like doing BID treatment, so it's not convenient for everybody. And the trouble is that when we did 10 fractions, that's 2 weeks. That's not that much more convenient than a 3-week schedule of the whole breast radiation. And so that was the impetus of creating a shorter, back to a 1-week schedule, but keep it at a daily fractionation. So we initiated this prospective trial, again enrolled 40 patients. In this trial, all patients were treated with second-generation skin dose optimized applicators. We did see a little more acute skin reaction. The numbers are actually very similar to the first trial, but as you saw in the first trial, for the second-generation applicators, we had no grade 2 skin reaction. Here we had 28%. When we looked at factors that influenced the probability of developing acute skin reaction, we saw that wider separation, obvious factor that influences skin dose, as well as the size of the applicator, were both important as far as the skin reaction. So patients that were treated with smaller applicators and had a separation of less than 7 centimeters, hardly any of them had any significant skin reaction, versus those that had both of those factors. The initial analysis of this trial we did at 14 months, and at that time we didn't have any significant late toxicity. Good text and cosmetic outcome was 100%, and there were no recurrences at that time. We're about 3 years follow-up, and so we haven't formally analyzed the data, but I see the patients for follow-up, and there hasn't been any surprises so far. And we'll do a formal analysis at 5 years. This is an example patient at 3 years follow-up, again, an excellent cosmetic outcome. So the third trial we looked at is the AccuBoost registry. And so this is open to all AccuBoost users who are performing APBI. And we welcome anybody who is doing this to register their patients so we can learn more from each other. There was a total of 252 patients registered in the registry. The dose was basically 3 different regimens: 34 grade 10 fractions, 36 grade 10 fractions, and 28.5 grade 5 fractions. The 36 grade 10 fractions comes from equivalent uniform dose calculations that we did, and based on the heterogeneity, it looked like we needed a little bit of higher dose to be equivalent to the other brachytherapy techniques, which are more heterogeneous. And based on that, we recommended a slight dose increase to 36 grade 10 fractions to be equivalent. The 28.5 grade was already calculated based on that EUD calculations to be equivalent. So those are the 3 fractionation schemes. The patient demographics are shown here. Here, again, the vast majority of patients fall into that group that's appropriate for APBI, although we actually did see some higher risk patients. We saw some patients that had positive margins, some patients that were actually node positive, some patients that were triple negative that were treated with this technique. 5% of patients had chemotherapy, so a relatively low risk group with a small percentage of higher risk patients. Acute skin reaction is, again, very reasonable with a low rate of moist disclamation, 4%. We have a wide range of median follow-up, with a median follow-up of 18 months. Late toxicity has been very good. There's only been 1% grade 3 toxicity. That was 2 patients that both had fat necrosis pain. The grade 2 toxicity was 8.8%, and the toxicities were telangiectasias, hyperpigmentation, subcutaneous fibrosis, fat necrosis, volume loss, and seroma. The cosmetic outcomes were fair to poor in only 2%, so 98% of patients had good to excellent cosmetic outcome, with 62% having excellent cosmetic outcome. In terms of local control, the ipsilateral breast tumor recurrence actuarial at 2 years was 98.3%, and at 5 years was 90.9%. And the freedom from true recurrence, so some of those recurrences were actually second primaries. They were in a completely different quadrant or had a completely different histology. And so we also looked at freedom from true recurrence, and that was 98.3% at 2 years and 95.4% at 5 years. And these are corresponding Kaplan-Meier curves. So to summarize, the advantages of the NIBB APBI technique is that it's non-invasive. So this is acceptable to patients who are not willing to undergo percutaneous placements of multiple catheters or indwelling balloon device. There's no device-related infection risk with this. Yet, by using breast immobilization and image guidance, we can have very small PTV margins and thus very small treatment margins, which have been associated with higher risks of toxicity and worse cosmetic outcomes. The breast compression further reduces the treatment volume by displacing non-target breast tissue out of the radiation field. So it sort of holds two purposes: one, to immobilize the breast, but two, actually to allow more precise, smaller volume of treatment by pushing the breast that we don't want to treat out of the way. The mammographic-like imaging, I didn't show pictures of this, but you can actually use the preoperative mammograms, which are typically taken in the same position as the treatment, to help localize the tissue at risk. This is particularly helpful if there aren't clips, or if you suspect that a clip's migrated. That can be helpful for delineating what the true at-risk tissue is. There's no, with indwelling balloon catheters, there's been reports of higher seroma formation. That's a non-issue with this. Lastly, oncoplastic reconstruction is used a lot more, where after the lumpectomy cavity, the surgeon just doesn't leave a cavity. They reconstruct the tissue to get a nice cosmetic outcome. That can be problematic for a lot of partial breast techniques, and this is not an issue with this this technique. And I'll show you a more extreme example here. So this is a patient who had very large breasts and had a small early cancer, and as part of her lumpectomy, she actually underwent bilateral breast reduction and then underwent an oncoplastic reconstruction. So as you can see, she has perioral incision and incision down in intramammary fold. The surgeon placed clips after the lumpectomy prior to the tissue rearrangement to delineate where the at-risk tissue was forming. Here's a CT scan showing where the clips are. And then here are the AccuBoost images. As you can see, we can target all the clips in both the CC and ML view, and this patient had a very nice treatment with partial breast irradiation. You certainly couldn't do a balloon catheter for something like this. There's no cavity, the tissue is rearranged. You could do interstitial for something like this. Not many patients are willing to undergo that. So with that, I'll open up to any questions that anybody may have.
Close to the chest wall. How close to the chest wall is this? Are you able to safely treat her?
So that actually depends.
Repeat the question.
Oh, yeah, let me go back there because I'm getting like an echo now. The question is, how close to the chest wall can you get with the applicators? And that actually depends patient to patient. We've actually looked at this formally. Some people, even if they have clips right on the chest wall, with breast compression, those clips can actually be placed between the mammography compression plates and targeted. For other people, we can't position them in an effective manner. So that is one limitation, is ability to actually be able to place the lumpectomy cavity and the target volume between the compression plates. The vast majority of people, usually about 75% of patients, are great candidates for this. Both for those who aren't, and we have to use a different technique. So typically, for logistics purposes, if someone's interested in this technique, I do a simulation, I image both angles. If things look good, then we schedule treatment. If we can't target it, then we look at an alternative means.
maximum size of treatment area is there for these?
So the largest applicator is 8 centimeters. And typically because the skin dose increases with separation, for the APBI, we've been limiting to 8 centimeter separation with compression. It's actually been very rare for someone to not be able to be compressed enough. But I think that also matters what part of the country you work in. Because I'm told in some parts with a more obese population, they have more issues with it. Yes?
How many oncoplastic patients have you treated with this? Because I have this. I have a surgeon who's very motivated to do this, but when you are dealing with that kind of breast, you can't compress it. I mean, at least the plastic surgeons I have, they make these women very perky. And you can't actually pancake it down.
Okay.
And unless I have the BioZor, the clips are everywhere. Do you have any thoughts on?
So the question is, sort of complicated question is, does this work for all patients, in essence, who go under oncoplastic? And the answer is no. Depending on how the tissue is ranged, exactly like you say, sometimes the clips will be throughout the whole breast, and that's not a patient who's a partial breast candidate at all at that point.
So are you having the surgeon, are you telling the surgeon up front this patient could be an AccuBoost candidate, and then that surgeon is trying to pull those clips together?
In some situations, yes. Obviously, this is it's a complex situation of what they can do to create a good cosmetic outcome. But when we identify a patient who's a potential partial breast patient is interested in a reduction as part of it, then they look to try not to manipulate the cavity quite as much so it's not all over the breast. Sometimes they're able to, sometimes they're not. And then ultimately I make sure that they label the at-risk area with clips so that I have proof that I'm targeting what I need to target in the end. And so if I go to doing the imaging and the clips are all over, then we have to change gears and do something different. There's a lot of complex interplay with surgery for this and plastic surgery. I think it's important when you're looking at doing this to sit down with them, show them what the technology we have and what capabilities we have and what the limitations are so that they understand what they need to give us so that we can effectively target patients and also be able to treat them with an easier modality. So some patients we can achieve that on, not everybody.
Can you talk a little bit about periareolar or subareolar targets?
Yeah, so periareolar targets are typically very easy to immobilize and target with this because they're very superficial and not very deep. And as far as issues with cosmetic outcome as well as toxicity on the nipple, we really haven't seen much issues with that. So that is actually this is actually a good technique for that particular location.
Thank you very much, Dr. Hepel. It was wonderful. He's, you'll stick around for a little bit if you do have questions.